Thoracic vasculitis, imaging clues and differential diagnosis. I'm Dr. Annie Fraser. I'd like to thank Haiti Wilson and Dr. Jared Christensen for their wonderful invitation to be a part of this great course. I want to quickly acknowledge the most amazing teacher for me in this field of vasculitis, and that's been the cardiovascular pathologist, Dr. Alan Burke. We'll start with a patient. This is a 58-year-old, just tested COVID positive with septic shock. These coronal CT reformats show us wall thickening of the ascending thoracic aorta, aortic arch, and takeoff of the great vessels with some relative sparing of the descending thoracic aorta. And a correlative PET-CT imaging study shows us that there is indeed disease activity in these zones of aortic wall thickening in the takeoff of the great vessels, as well as an unsuspected zone of aortic wall inflammation at the level of the diaphragmatic crus. There is certainly a great deal being written about COVID inflammation and vasculitis. We know that this is going to be an issue of ongoing investigation. It is reported in both acute COVID infection as well as long COVID. COVID vasculitis can affect the small, the medium, or now we see the large size vessels. So aortitis in COVID is something that may actually be underdiagnosed at this time. The pathogenesis is likely multifactorial, where we know, of course, systemic hyperinflammatory response is impacting vascular endothelium, but we also know there may be some immunologic drivers such as type 3 hypersensitivity. And finally, it is now being reported that it's possible COVID infection may actually initiate or unmask other more clearly immune-driven vascular disorders, including giant cell arteritis and lupus. I will just emphasize that thoracic vasculitis, in fact, all vasculitides are very much a multidisciplinary diagnosis, including clinical history, seromarkers, tissue analysis, and so forth, as well as our imaging findings, which are mostly supportive. I'm going to describe the idiopathic large vessel vasculitides in detail, as well as the ANCA-associated vasculitides, because these are things we encounter a little less commonly, and I just want to give you a framework as well as sort of an illustrative reminder of these entities, and we'll also talk about the spectrum of diffuse alveolar hemorrhage. So yes, imaging findings are integral to multidisciplinary evaluation, including history, serology, tissue analysis, with supportive imaging findings. And our imaging modalities that we can offer include CT, MRI/MRA, and FDG PET-CT, all providing some complementary information. And finally, our imaging can support not only an accurate diagnosis of a suspected vasculitis, but also assist in clinical management. We can provide information concerning unsuspected underlying vascular complications and soft tissue complications. We can guide tissue sampling with our imaging findings. We can also detect sites of unsuspected relapse or flare. The American College of Rheumatology provided a very comprehensive consensus statement in 2012 related to the classification and nomenclature of this extremely broad field of vasculitis. And when it came down to it, they again are approaching this topic in terms of vessel size as a guideline for classification. And so we continue to do that to this day. And building on that early work, there are some more recent consensus statements with guidance for both large vessel vasculitides and the ANCA-associated vasculitides that have been put out by the European League Against Rheumatism, called EULAR. And this is part of the European Alliance of Associations for Rheumatology. So this is a very evolving and dynamic field. Under the microscope, there are hallmarks of vasculitis. As we see in this high-powered slide, the intima is typically very thickened. Remember, this is normally a very delicate thin structure. And second, and more important, the medial compartment of the vessel wall demonstrates these smudgy pink zones under H&E, which represent areas of tissue necrosis. We can see on this elastic stain of a coronary artery that vasculitis is classically a transmural inflammatory process, in this case digesting away internal elastic lamina, medial compartment, and external elastic lamina. Notice also that a vasculitis does not need to involve the entire circumferential zone of a vessel, but it may also be an eccentric process instead. A segment of an inflamed vessel may go on to develop pseudoaneurysm formation or even localized dissection. Localized changes in the hemodynamics of a vessel or endothelial properties related to coagulation may induce localized thrombosis. It may become an organized thrombus over time. And finally, even a segment of healing following an episode of vasculitis can be problematic. This is looking at the intimal surface of a segment of an aorta that shows extensive fibrotic tissue that has been laid down in a disorganized way. It has led to a stenotic segment of the aorta, but also it has led to compromise of the ostia of the takeoff of some of these aortic branch vessels. So we'll really start our journey now with the large vessel vasculitides, including Takayasu arteritis, giant cell arteritis, and Behçet syndrome. Takayasu arteritis is largely a large vessel vasculitis of younger women. The aorta, as well as its proximal arterial elastic branches, are typically involved. Please don't forget that Takayasu arteritis may also include the coronaries and the pulmonary arteries in up to 70%. This is a granulomatous vasculitis with two classic clinical phases. The initial phase, usually in the teens and early 20s, is systemic or quote-unquote inflammatory with constitutional symptoms and an elevated SED rate, and often, unfortunately, the diagnosis can be missed at this point. The second phase is the more occlusive or fibrotic phase of Takayasu arteritis, which is expressed with ischemic symptoms, high blood pressure, and bruits, for example. And this would be where sites of stenosis and end organ damage may be found. I'll show you some imaging examples of Takayasu arteritis, including findings of wall thickening, aneurysm formation, stenotic segments in a skipped pattern, which is very classic for Takayasu arteritis. In other words, not long contiguous zones of involvement, but rather skipped lesions. And PET-CT can be positive in stages of active inflammation, as in many vasculitic syndromes. Here is a young adult female who honestly had several years of intermittent chest pain before she came to medical attention. They found, when she finally walked into an ER, EKG changes, a high SED rate, a coronary arterial study shows us multiple coronary artery aneurysms. Now, the differential diagnosis initially was either mycotic aneurysms or Kawasaki disease, but ultimately the diagnosis with full clinical and seromarker evaluation was Takayasu. Here is another young adult female. She presented with upper extremity paresthesias and a high SED rate. This beautiful MRA shows multiple bilateral subclavian artery aneurysms in a skipped lesion pattern. Someone wasn't entirely distracted by those beautiful findings because, in addition, a focal aneurysm was detected in the middle of the chest. And further dedicated cardiac imaging did reveal that there was a saccular left main coronary artery aneurysm. So, just as an important cautionary tale, in a patient with a large vessel vasculitis, especially in this case of Takayasu, coronary artery evaluation is also very important. Here is another patient in the systemic or active inflammatory phase of Takayasu arteritis. And on the left, we can see that her descending thoracic aorta shows remarkable FDG PET CT uptake in the aortic wall that is somewhat eccentric, associated with some eccentric wall thickening. And her MRI post-contrast shows some patchy aortic wall enhancement. This was pretty immediate, showing very active inflammation as well. In this same case, we can see that there was unsuspected involvement of the lower abdominal aorta and the takeoff of the iliac vessels. Notice that there is some focal FDG uptake in that location. Very important because this establishes also a baseline for this patient. So now we're moving into the more fibrotic phase of Takayasu arteritis. So on the left, we see a sagittal CT reformat of the descending thoracic aorta, which has a segment of fusiform narrowing in the lumen itself. The aortic wall actually demonstrates a lot of soft tissue thickening. This is reflecting those zones of fibrous tissue that have been laid down as attempted healing. On the right, we have a 3D volumetric MRA posterior view, where we can see, again, a corresponding segment of luminal narrowing of the descending thoracic aorta, as well as a little bit of post-stenotic dilatation of that lower descending thoracic aorta. Again, fibrotic phase, and we can see that, yes, Takayasu almost invariably involves the aorta, but there is certainly variable extension, often with skipped lesion patterns, in the elastic arterial branches coming off of the aorta. Okay, so on the left, we have a posterior view coronal MRA of the upper thoracic vascular anatomy, and we can see this tapered narrowing of the left subclavian and left common carotid arteries. And although as a thoracic radiologist, I'm very intimidated by subdiaphragmatic anatomy, we have here another young adult female about a decade after her initial diagnosis with mixed sites of aneurysmal dilatation and stenosis involving her renal artery anatomy and hepatic artery anatomy. So we can see that even in supposedly the fibrotic phase, we can have a blend of aneurysm formation as well as stenotic segments. So here is some dedicated right and left coronary angiography in a patient with fibrotic phase Takayasu. We can see multiple skipped lesions of long segments of coronary arterial luminal narrowing. And that correlates on the left with heaped up areas of intimal fibrotic tissue, as well as zones of chronic thrombosis. Now, this patient underwent coronary artery bypass grafting because the placement of endovascular stents in this situation is usually contraindicated. Here is one last example of Takayasu arteritis. This is a complication that developed in a patient who was supposedly in the post-inflammatory or fibrotic phase of the disease. She presented with a type B thoracic aortic dissection. Now, to me, this teaches me that even in the fibrotic phase of a large vessel vasculitis like this, there is probably some weakening or compromise of vascular integrity due to disorganized patterns of healing. Secondly, no one is going to put an endograft in this patient because, again, endovascular intervention is, in many cases, contraindicated. And this patient was just followed over a period of months to years. And this type B dissection partly resolved over that time. Now, in my prior life, I was an art historian, and this painting in particular is actually quite beloved by the rheumatology community. And this is because the artist, Jan van Eyck, painted this, and he was almost, in his precision, a medical illustrator. The man that commissioned this painting, a clergyman, had been quite ill for a number of years. We can see in this photorealist painting provided by Jan van Eyck that he has some engorgement or dilatation of his temporal arteries. He has hair loss of his lateral brow line as well as his hairline in that location. We also see some swelling of his left hand, which is called chronic sclerotic edema in the rheumatology community. So to a rheumatologist, this is a classic appearance of giant cell arteritis, also known as polymyalgia rheumatica. And it wasn't too long ago that I actually found a very similar case depicted in the New England Journal of Medicine of modern day giant cell arteritis. Now you may wonder why I have a giant cell arteritis section in a thoracic vasculitis talk. Well, this says it all. This is a case of a 60-year-old female with headaches, high sed rate, and chest pain, ultimately diagnosed with giant cell arteritis, also known as temporal arteritis. Notice that the PET-CT lights up the thoracic aorta and the takeoff of the aortic arch vessels remarkably. So this person clearly had involvement of the aorta. Giant cell arteritis is diagnosed in a much older population than Takayasu arteritis. These patients are almost always greater than 50 years old. There is still somewhat of a female preponderance of cases. Another word for giant cell arteritis is temporal arteritis and polymyalgia rheumatica. And we classically remember this from med school as a patient with headaches, visual changes, polymyalgias, high sed rate, and so forth. And it's even considered an ophthalmologic emergency at initial onset. It classically impacts medium-sized extracranial vessels of the head and neck, and it is a granulomatous vasculitis, very similar to Takayasu. But I just want to take the opportunity to remind you that in a small group of giant cell arteritis cases, thoracic aortitis and coronary arteritis may develop. And there is in these patients an increased risk of aortic aneurysm formation, aortic dissection, rupture, and even myocardial infarction. So we should always keep this in mind with a diagnosis of giant cell arteritis. My last large vessel vasculitis is Behçet syndrome, which is more typically arising in young men, age 20 to 35. It's called the Silk Road syndrome because many of these folks affected can trace their ancestry back to the Silk Road spanning Turkey to China. We clearly think there's a strong genetic component here. It is an immune complex deposition-driven vasculitis. It is aggressive with a high morbidity and mortality with a clinical triad, which was part of its original description in the early 20th century of stomatitis, genital ulcers, and uveitis. We bring Behçet's into our discussion here because it may also, again, in a minority of patients, impact the large and medium-sized pulmonary arteries with aneurysmal dilatation, as well as, in some cases, intracardiac thrombosis. So this was a young adult male who came into an emergency room with hemoptysis, and they observed oral ulcers. As part of his workup, a CTA was performed to rule out PE. You can see these images, which are coned to the left chest, that he has multiple pulmonary artery aneurysms, and that I've shown with yellow arrowheads that there may even be some erosive changes in the wall of the largest aneurysm centered in the left lower lobe. Unfortunately, within a few weeks of admission, this patient died of massive exsanguination into his left hemithorax related to rupture of this large left lower lobe pulmonary artery aneurysm, which we can see here on the gross autopsy specimen in the center of the slide. Close histologic examination of this pulmonary aneurysm wall showed extensive both active and chronic and partly healed signs of inflammation, as well as acute on chronic thrombosis within the lumen of that pseudoaneurysm. And it really shows you not only the aggressive but also necrotic character of this particular form of large vessel vasculitis. Moving on to the ANCA-associated vasculitis syndromes, we talk about the top three as granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. In general, these systemic vasculitic syndromes share a clinicopathology. They are granulomatous-driven inflammation. They can be necrotizing. They are considered idiopathic, and in many cases demonstrate ANCA-positive serologies, depending upon the variant and the presence of disease activity. These are limited to the small and medium-sized vessels, have overlapping clinical features, and respond to immunosuppressives. Many descriptions of GPA include the presence of pulmonary nodules and zones of mass-like consolidation that tend to be centered around the bronchovascular bundle. Also, they may be termed angiocentric. They tend to be multilobar. Ground glass margins around these zones of consolidation reflect hemorrhage. We may also see zones of focal volume loss within the lungs of a person with GPA due to underlying stenotic intralobar airways. The consolidations of GPA tend to have an unusual characteristic of cavitation, especially when those zones of consolidation exceed 2 centimeters in size. Under the microscope, these zones of cavitation are correlating with geographic necrosis, which is very aggressive and necrotizing granulomatous inflammation. Now, I think of this as sort of a sister disease of GPA, but certainly there is a different clinical scenario here. We have a 40-year-old female with new onset asthma, chest pain, and peripheral eosinophilia. Her opacities, again, are peribronchovascular, multilobar zones of consolidation with extensive patchy zones of adjacent ground glass opacity, which we know correlate with zones of parenchymal hemorrhage. These opacities can wax and wane, but these opacities do not typically cavitate. Yes, this is a granulomatous and necrotizing vasculitis, but the additional component here is tissue and peripheral eosinophilia. And the granulomas are called allergic granulomas. These are multinucleated giant cells that are palisading around eosinophils, trying to bring them together and wall them off. These allergic granulomas form in the myocardium, the skin, the kidneys. Overall geographic necrosis in the lung is very atypical, so you're not going to see classically cavitation in lung consolidations in Church-Strauss or EGPA. And very importantly, the allergic granulomas and tissue eosinophilia of EGPA impacts the myocardium in at least 60% of cases. We'll finish up with pulmonary capillaritis. Now, clinically, we think of this as diffuse alveolar hemorrhage syndrome with hypoxemic respiratory failure in advanced cases with anemia, hemoptysis only in about 2/3 of patients, and a mortality that can reach 50%. The diagnosis, the gold standard, is serial bronchoscopic lavage, where red blood cells are drawn back on repeated saline installations into the subsegmental airways. So if we look under the microscope, we can see that there is widespread but perhaps patchy alveolar wall thickening due to neutrophilic infiltration, and the pattern is called alveolitis by the pathologists. This form of inflammation leads to gaps in capillary basement membranes. Red blood cells then spill into the pulmonary alveolar interstitium, as well as the alveolar spaces, which we call diffuse alveolar hemorrhage. And of course, this is leading to a remarkable decrease in alveolar surface area that compromises our gas exchange. The non-immunologic driven forms of capillaritis include infection, ARDS, and drug-induced lung toxicities. For example, here is a case of what's called differentiation syndrome. This is an ATRA, drug-induced lung toxicity, administered in leukemic patients with consequent capillary leak and diffuse alveolar hemorrhage. But we also have to remember the immune-driven small vessel vasculitis forms, including pulmonary renal syndromes, which is a pairing of diffuse alveolar hemorrhage and acute glomerulonephritis. This would include the ANCA-associated vasculitis syndromes, such as GPA and MPA, systemic lupus, and anti-glomerular basement membrane disease. We also know this as Goodpasture's. Now, this is a case of pulmonary capillaritis in the setting of GPA. So although we sometimes see multifocal zones of consolidation, as I've shown already, we may also see diffuse capillaritis in a GPA case. And this was so devastating, the patient did not survive the episode. Our final case is a young adult male who presented with shortness of breath, anemia, and renal failure. We see these multifocal zones of ground glass opacity in all 5 lobes. So it's time for me to sum up, and here's some take-home points for us as radiologists. Vasculitis is a collaborative diagnosis that is combining clinical, lab, and biopsy results along with our supportive imaging findings. We've reviewed some of the more common etiologies of vasculitis, especially in the chest, including infection, drug-related effects, toxic insults, and of course, those immune-driven factors. The general categories of vasculitis we should keep in mind are large vessel vasculitis, ANCA-associated vasculitis, and capillaritis syndromes. And please keep in mind that there can be overlap in the caliber of vessels involved. In other words, I showed you cases of large vessel vasculitis that also impacted medium-sized vessels, right? I showed you some ANCA-associated cases that not only infected medium-sized vessels, but also the capillaries. And I just wanted you to see something that will be included in your slide deck, where I have summarized by modality some of the classic and key imaging findings of vasculitis in the chest. This is CT and CT angiography. Here are some of the relevant findings and clinical impact of using FDG PET-CT in evaluation and management of thoracic vasculitis. And finally, the well-recognized findings on MRI and MRA of vascular wall inflammation. Thanks everyone for your kind attention.